I'm going to go over the uh, three categories that usually I process in my brain in regards to diagnoses of children that I usually see. One is neurologic, one is musculoskeletal, the other one is lack of coordination or delayed milestone. So the first one I'm going to go over is neurologic diagnoses and progressive. Um, Ones involving the brain are tuberous sclerosis. There are certain benign tumors that that is progressive, and then Rett syndrome is a progressive brain disorder. Neuromuscular are muscular dystrophy, spinal muscular atrophy, myopathies, and other muscle disease. And just an aside, oftentimes myopathies or muscle disease may come to you under the category of delayed milestones or lack of coordination. I could also use the term lack of normal physiological development, but that diagnosis could come with any condition. Then you have the neurologic diagnoses that are non-progressive. Involving the brain would be CP, traumatic brain injury, stroke, lissencephaly, which is smooth brain, spinal cord, spina bifida, spinal cord injury, and peripheral nerve would be Erb's palsy, reflex sympathetic dystrophy. We've seen that after kids have had strokes or other traumatic conditions come in with RSD. And then in your objective exam, you will, if they are under 2 years old, you will do developmental testing. But I suggest that it is optional once they get older than that, because if they are complex, CP child, the gap as compared to typical developing children when doing developmental testing, it can be frustrating for the family and the child to hear, gosh, I'm 10 years old and I'm functioning at a gross motor level of 6 months. So, I put that out there to use your judgment on that. And then also from insurance aspect, if you have a child that's 10 years old and you give them a gross motor age of functioning at a 6-month level, then 3 months from now they're functioning at a 7-month, or they're still at a 6-month level, but let's say they can do something functionally a little bit better. Let's say a transfer with less assistance. They've gained a skill, but their functional level or their gross motor skill level has not changed. So just throw that out there. And then you want to do passive range of motion, active range of motion, clear neurologic with reflexes, sensation, proprioception, and you want to look at their balance, writing, equilibrium reactions, postural control, and manual muscle grades or myotones would be for your neuromuscular and spinal cord, and these are often difficult to obtain because you've got muscle imbalance. With that, you may also be fighting contracture. So looking, for example, spina bifida, oftentimes the hip extensors are weak, but then their hip flexors are so active, they're tight in hip flexion, and they have difficulty with control, active control of the abdominals in order to maintain a posterior pelvic tilt, so which can affect too when you're testing any of the hip muscles. So that's just to consider. And then you're going to look at functional mobility transfers, gait, posture, and any current DME, splinting, or orthotics. And I already talked about developmental testing and my opinion on that, and they often do not account and assess the asymmetry of the movement patterns, or even track when there's improvements of those movement patterns. So that's just something to consider in developmental testing. Neurologic diagnoses presentation generally. I want to give you general guidelines. Their range of ability is going to be from one extremity involvement to total body involvement. Most likely their difficulties are due to muscle tone, either increased or decreased, and resulting muscle imbalances are their primary issues limiting function. They most likely also have impaired or altered proprioception, sensation, vestibular, and vision. Cognitive impairment may or may not be present. Orthotic and DME support may or may not be needed to improve independence. It can, depending on complexity. And there is an intense requirement on family participation in the home program. The families are the ones that are going to have to really be actively involved in this child to prevent contractures and maintaining the child's range. So family education and instruction is greatly needed. And then you're going to also begin to educate them on the fluctuating frequency from intense bouts to more consultative roles. You have to begin to address that. And this can be a hard topic because they're also going through stages of grief. And I've had some parents be almost tense over the fact that if their child's not making gains, they're not going to be able to see me as frequently. So you have to walk them through that process, not just immediately discharge them for not seeing the progress. There has to be a conversation and communication going on. And I just briefly want to go over tone, hypertonicity. I tried to summarize with spasticity and rigidity, the differences, and hypotonicity in the neurologic realm. They have to have normal DTRs or increased DTR to be diagnosed as hypotonic CP. Doctors often use hypotonia or low tone as a way to, and can be a descriptor of just the muscle feel, but they may not be true hypotonic neurologically. Dystonia is fluctuating tone. Athetoid is also fluctuating tone and is kind of going away in use, but it is characterized by decreased association of the head and arm movements. And I don't have a video of someone with athetoid, but most likely the 18R is still present, so you'll see them whip them over to the side with their arm go in order to turn. You'll see their arm go with them. So hopefully that was a pretty good one. And ataxia, they have an intention tremor. Wide base of support is usually seen in sitting, and they'll brace and support themselves in multitudes of ways. Like you'll see them put an arm down kind of just on their leg in order to balance themselves, because they are trying desperately to hold on because of the constant movement as they're attempting to walk or transfer or transition. Then as far as tone management, you can, for high tone, splinting orthotics and positioning are key to help maintain. And and those who have the range, when you overstretch or not overstretch, but stretch a muscle, you can cause an inhibition and allow some activation in the muscles that are lower tone or not as active. And oftentimes the flexors in the upper extremities are more tight, usually just because those are the muscles in our body that are stronger. So if you can stretch those muscles out, sometimes you can begin to see some more activation in the extensors, and you want to focus on that. When you're doing passive range of motion, and I demonstrate this in one of the videos, you have to be slow and patient. You have to kind of wait and then bend. Oftentimes in the lower extremities, it's the extensors that are really pushing down, and you have to break that pattern. So you're going to go at the hip, try to flex the hip, and if you're just holding it and you just wait, eventually they're going to flex. And if you can keep the environment calm, because oftentimes high tone will just increase with excitement and with high activity. So you want to be aware of that. And then you're also the one that can make the recommendation on, you know what, I think a little Botox, a little baclofen may help this child. So you need to have kind of an awareness of those medical interventions. Not that you will make that primary decision, but at least you're making the referral for the family to help the child and help in your therapy sessions. If the tone is just kicking in and affecting their gait quality and their movements, you know, you want to have a neurologist or a physiatrist or a medical professional begin to assess that. Then the other category is musculoskeletal disorders, and these are as an orthopedic therapist, these diagnoses, you can use what you already know about the alignment of the body and use similar testing that you do on a daily basis, except it's like the first one is congenital muscular torticollis. It's a baby. So you're going to have to set up your environment where you have some toys, light up toys, musical toys, and if you don't have that, you have the family help to engage, because in young babies, often it's the facial expressions of parents and just being silly, making noises they'll respond to even more than in toys. So be creative with that. Metatarsus adductus, hip dysplasia, arthrogryposis. And arthrogryposis is just it can involve the joint, it can involve the nerve, it could involve the muscle. And really you have to have, with these children, you need to have a medical team involved that really is assessing to see what's going on with the child. And I do have a video of Raylyn, and she does have arthrogryposis, and sometimes they're total body involvement, sometimes they're just one arm or just the hands. And you know, with a lot of surgical intervention, and you can make an impact with the child. I had recently a child, he's now walking. The only concern is he's got extended arms, and so he's at risk for breaking an arm, so he still has to use an assistive device. But when I first saw him, he was just sitting and really stretching and range of motion. It appeared Mom was doing consistently, we were doing consistently, even though he was very resistant to it. We could not get the range necessary to allow him to stand. So he had a lot of surgeries in order for him to be moving. Scoliosis, Erb's palsy, you know, is a neurologic condition initially, but you have orthopedic involvement just because there's usually some increased tone in certain muscles or muscle imbalance, and you'll be doing a lot of passive range of motion and stretching, So you can go from the fact that there is going to be musculoskeletal involvement, and you can also have some torticollis involvement just from the Erb's palsy pulling on the avulsing of the brachial plexus. You can affect the neck too, so you need to be considerate of positioning. And then postnatal. Musculoskeletal disorders, osteogenesis imperfecta, amputations, and that's not always postnatal. Sometimes there are banding, amniotic banding, where you can have missing limbs when they're born, and Legg-Calvé-Perthes disease, slipped capital femoral epiphysis, tibia vera, limb length discrepancy, idiopathic scoliosis, juvenile rheumatoid arthritis. And you're going to assess just as you would, oftentimes these diagnoses are can be intimidating because you've especially like JRA, you've got multiple joints involved also. You just go on the fact that you're going to get as many findings as you can appropriate to the diagnosis. It may require you to just look it up, review it a little bit on that specific diagnosis and what characteristics there are, but you know, you're a physical therapist. You can assess range, you can assess strength. I'm not certified as a pediatric PT, but I've done research what I've needed to do and sought out mentoring in order to do what I do. So my belief is that any physical therapist can work with pediatrics. You just have to have the heart and the desire. So and just be willing to look into these diagnoses. Don't let them intimidate you. And your musculoskeletal, the objective, developmental testing is optional. If it's going to help your assessment and give you a clearer picture of the child, by all means do it. But you're going to do passive range of motion, active range of motion. And reflexes, sensation, proprioception, usually not an issue when you get when you get these diagnoses. You know, you're screening it, but you don't necessarily have to include it in your evaluation. Postural control, motor control, torticollis and Erb's palsy. You want to look at those in the babies because the position of the head and their lack of head control is going to be affected. Is going to affect their ability to of the neck complex or the shoulder complex. If they've got poor neck flexor control, good luck at really getting good, nice active rotation because they can't maintain a head in neutral. And then lateral reactions are the last part of head control to develop. If they don't have neck flexor control, good neck flexor and extensor control, lateral control is going to be difficult. You want to look at their balance, righting, and equilibrium reactions, especially with arthrogryposis. There's weakness in other areas. Manual muscle grades for children that consider their age and their ability. But if you can obtain them, do obtain them. Transfers, functional mobility, gait, posture. And general presentation of those with muscular skeletal disorders. And we all know that primary diagnosis with musculoskeletal involves muscles, joints, bones, or cartilage. Simple one joint to the total body. Range of motion, strength, postural alignment will be a significant part of your assessment. And positioning, splinting, orthotics to maintain and improve range of motion and posture will be key. Prostheses for amputations. DME may be required to increase independence or post-surgery. And cognitive impairments are rare unless there is another diagnosis on top of it. And asymmetries and dysmorphic features may or may not be present. So just be prepared. When you've got multiple joints involved, you can have other features of the face also involved. And then delayed milestones, lack of coordination. This is their presentation. They are usually low tone or hypotonia in the fact that they're low tone with usually hypoactive DTRs, differing from the hypotonic CP as I went over earlier, where there are increased or normal DTRs. Developmental testing is extremely helpful in setting goals and monitoring progress. There's not going to be the hugest gap compared with typical developing children, so oftentimes it helps give you a guideline for your goals of what they need to achieve next. And they may or may not have cognitive impairments. Be aware of their difficulty. Oftentimes these children have difficulty with sensory processing and motor planning often present. I've had children that are really hypoactive in their proprioceptive system or sensation. They're seeking all this input and they crash and bang into everything, and it can appear like, wow, this kid has horrible balance. Well, he actually likes throwing himself down on the ground because he likes that feel. So just be aware that there might not be a real balance issue. There is a hypoactive proprioceptive system. So you have to instruct the family on this is what he needs um, in order to meet that system need that he has. Uh, Lots of jumping, wheelbarrow walking, those type of things. And that is not a real objective assessment. And so oftentimes I'm not necessarily trained in sensory. I call upon my occupational therapists who know a little bit more on that side, but it is something to be aware of. And then also range of motion or flexibility limitations caused by weakness or muscle imbalance. These kids are usually, as babies, they're very floppy. They have no range limitations. You get them a little bit older though, and they're not moving the way typical children do, and they're tight in their hamstrings, they're tight in their hip flexors, they're tight in their adductors. So it's something to address and look at because they're just not moving like kids who are running and jumping, and so they're predisposed to other problems, foot problems, back problems, because they're not moving as much as their peers. These are conditions that usually will have the treating diagnosis of delayed milestones or lack of coordination. Autism, pervasive developmental delay, which is just another terminology used to describe that they're on the spectrum of autism, but these children usually present a little bit differently and often have a little more lower tone. Hyperactive or ADHD kids can have some lack of coordination. Down syndrome and any syndrome diagnosis that is suspected can have a delay or lack of coordination. And then also long-term hospitalization due to other medical conditions like heart conditions. You can have some kids that have this and it just impeding their function. And really, I just wanted to, as far as what your assessment is, like I said, developmental testing is real necessary, and your passive range of motion, active range of motion, screening, and then reflexes. Well, not. It's good to document what their reflexes are. Sensation. It's not going to follow a dermatome. It's going to be more a general assessment. Like they might not like the feel of certain things on their skin, or they may like the feel of a lot of textures, so they're always putting themselves in the ball pit anytime rice and beans are around, which is something OTs use a lot, and we use for balance, walking along those things. They might stick their arms and feet and everything in that, so just be aware of that. And then also proprioception, you're observing how they're responding. Are they always going to the trampoline? Are they, walking and stomping, and what are they doing functionally that would give you a clue that, you know what, he needs proprioception. I've had some children that their balance is not good on even ground. I put them on a foam surface, their balance is better. It's like they need that unstable surface to provide some more input. So while it is not real objective, it is something to consider in your treatment plan when you're trying to improve function. So postural control, motor control, balance, writing, equilibrium reactions, and manual muscle grades. If the child can't follow directions, they are helpful, but if they're not good at following directions, you might not be able to obtain a lot of information. But these kids are going to be weaker in the midsection usually, in the abdominals and the hips, more often than not. And then transfers, and you're looking not just their ability to get up and down from the floor, but do they always put their hands on the floor? Can they transition from a half knee to stand? Can they squat and get back up without upper extremity support? So you're looking at all those things, functional mobility, gait, posture. Look at how they do things, not just can they do it? So, and I just wanted to make suggestions on when communicating other referrals. Oftentimes in pediatrics, we are helping the physician begin to diagnose this child. We are beginning to paint a picture for giving the physician some findings that maybe they didn't observe or notice to help in the diagnosis. So when you, because I've had instances that I find the spasticity, the increased reflexes, the deep tendon and primitive reflexes, and I have to note to the family that I'm going to share this with the physician, and I've been given just a diagnosis of delays, but cerebral palsy is suspect. I can't give that information directly to the family that that's the diagnosis, even though maybe I'm suspecting that. I need to have the physician do that, but I need to explain to them that these are findings that let you know that there's some sort of involvement with the brain, and this will be, you will discuss with your physician for further information. And I may give the doctor a call or make sure there's a note on the front that these findings were discussed with the family and consideration. Oftentimes it's a pediatrician that sends them to us, so I'm going to make a recommendation that they go to a neurologist to confirm any findings. And and I let the family know, I'm not a doctor. These are just findings that hopefully will help the physician in making a diagnosis. And then you also want to avoid, like, especially autism or autistic-like. If you see some arm flapping or things that we're learning about are that may not be in our scope of expertise, but we know are signs of autism, you don't want to express that. You want to maybe express those observations to the physician, but do not use those labels in the family. It will it can breed difficulty with the physician. It can breed difficulty with the family because we're not the ones giving the medical diagnosis. So I just want to hit that. And let them know also, like, if you're planning to refer them to OT, PT, or give them a wheelchair or orthotic, make sure you're just communicating all of that with the family. And then just briefly with the physician, you just want to prepare beforehand what you're going to say. Want to consider it written down right in front of your face, and follow up them if they're not returning your phone calls, but include the family in the follow-up. Don't let it all be on you to get that information, because sometimes family will let you do that because they don't understand the medical system as well. Help them through the medical system, but don't let them put the responsibility completely on you. And you should be confident and friendly with the doctor, and try to consider the style of communication of the doctor when communicating, and just be prepared, succinct, to the point. And in my opinion, is it okay to admit if you're unclear on what he wants, and request clarification from the physician. Don't be intimidated by that. And so, just in conclusion, I don't know if you can tell, I'm pretty passionate about what I do. I love the kids, I love the families, and oftentimes we're the connector to the family to services within the community. So we assist the physician, we help provide other medical referrals to improve the child's function, always keeping the child in mind. But because PTs impact really the child's function, oftentimes there's a huge bond that develops with the family, the child family. So improving the functional outcome of the child can be very rewarding for both the therapist and the family and the child. It also can be very frustrating for the PT and the family. The child's not making a lot of improvements. Therefore, pediatric PTs must be excellent at communicating with the family and helping guide the plan of treatment with realistic goals and steps. And meanwhile, no matter the severity of involvement, their child's PTs, still a physical therapist, we need to still allow the family to go through their process of acceptance of whatever the condition is. I mean, you might think families who have a child with torticollis. You know, it's simple, it's resolvable, it's treatable, it's done in a year usually. But they have their own process to go through. Sometimes they question themselves and they go through stages of grief if their child has a head tilt. So we have to allow them to go through their process and then make referrals to help the family if we see that it's getting unhealthy, or consult with people. But we want to just not judge or criticize or assume things about the family. So anyways, I just want to thank you for your time.